Hi, good afternoon, everyone. On behalf of the Michigan Department of Health and Human Services Heart Disease and Stroke Prevention Unit, Henry Ford Health System, and the Michigan Society for Cardiovascular and Pulmonary Rehabilitation, we would like to welcome you to today's webinar. My name is Karen Fuller, and I'm a public health consultant with the Heart Disease and Stroke Prevention Unit at the Michigan Department of Health and Human Services. I serve as the Community Clinical Linkages Specialist and also the co-lead for the Michigan Million Hearts Initiative. As part of our CDC grant-funded work, we have teamed up with Henry Ford Health System and MSCVPR to increase enrollment, referrals, and participation in the cardiac rehab. We have had such a great response to this event and have several in attendance. We ask that you please keep yourself muted, and after the presentation, there will be an opportunity to ask questions. In the meantime, please use the chat box if you're on the Skype app to ask your questions, and I will facilitate the discussion at the end. For those on the line, we will have an opportunity for you to ask the questions at the end, and you will again start 6 to unmute yourself. Next, I would like to introduce our speakers. Dr. Stephen Catane is the Director of the Cardiac Rehabilitation Preventative Cardiology Unit at the Henry Ford Hospital in Detroit. And he is also the grant recipient of our Michigan Department of Health and Human Services grant, 1817 grant. Diane Perry is a certified clinical exercise physiologist and a certified health and wellness coach at the Michigan Medicine, with 20 years of experience working in cardiac rehabilitation and diagnostic stress testing. She is also the chair for patient family-centered care within the Department of Preventative Cardiology. She is a member and past presenter of both MSCVPR and AACVPR. Now to you, Dr. Catane.
There you go. Karen, can you hear me now?
Hi, yes, we can.
We can't hear anybody.
Dr. Catane.
No, this is Stephen Catane. Can you hear? Can the audience hear me now?
The audience is muted, but yes, we can hear you now.
Yep, I'm getting a lot of you.
Yes, we can.
We're set. So thanks, Karen, for the introduction. And Sahil, could you take me to the next slide? So I know this has been an awful lot of change for us over the past 8 weeks. And what I'd like to do over the next probably 30 minutes or so with the assistance of Diane, it's bounce through these items that you see here. Next slide, if you would, Sahil. Before beginning, I want to formally thank MSCVPR and Michigan Department of Health and Human Services for really pulling this together on short notice. And equally want to thank Diane Perry for University of Michigan for, again, working on short notice to get this together for you all. Next slide. So this is, in some ways, this is my disclaimer, and all decisions relative to this, I'm getting the sense, are going to be local. So I encourage everybody that is involved with cardiac rehabilitation, as you're trying to decide and address a lot of the questions that we're going to raise today, is see what your local physician, administrator, infection control people advise on the different topics. I know we have an awful lot of input, an awful lot to think about, an awful lot of change, but at the end of the day, we're smart enough, we're quick thinkers enough, we've got enough bandwidth, good common sense, good clinical practice, and we can restart our programs in a really sound and safe way. And a lot of it will reside, as I mentioned, locally in how you progress. One of my biggest goals for today is not to answer your questions as much as it is to help you know maybe what to think about and what questions need to be answered. My guess is many of you have already thought about this, so in some ways it may be redundant, but yet maybe we'll provide some new information. Next slide. So there are external factors that we have to consider as we reopen our programs. I know some programs have already opened, some programs are opening next week, and some programs are going to open week of May 18th, and then after that. But there's obviously an executive order that your local people are considering as they open up hospital services. Then you have your own health system policy in recognition of the executive order or its interpretation of the issue, and some of it will depend upon, a lot will depend upon where you're located in the state, what county. And then in addition to any state level or institutional level decisions about opening services, then there's also what is your department thinking, what is your division thinking, what is, if you're in rehab medicine, what's the thinking there, if you're in cardiology, what's the thinking there. So there'll be that level of decision making as well. Next slide. So one of the big topics, and this is where I'll spend a fair amount of time before handing it off to Diane, who is then going to hand it off back to me to finish, is who do we start in our program? And there's no right or wrong here, but I wanted to throw out some things to think about. And first off is we have a unique opportunity here that we are going to have a foot in both worlds. Many of you have shut down your programs totally, and many of you have kept either a telehealth model or a telephone-based model to stay in touch with your patients. Now, as you restart, you may have some patients that don't want to come back to you right away because for fear of contracting a COVID virus, and so you might have to maintain them with telehealth or telephone. So you may have a foot in both camps, starting rehab, brick and mortar, as well as maintaining patients at home. So one question you might want to think about in terms of restarting patients is, do you start first with patients that want to come back when you close your programs down on March 23rd? That's a consideration, kind of first in, first back in, first out, first back in. Do you sequence the enrollment based upon discharge date? If you've got somebody that was discharged one week ago with an uncomplicated PCI, do they get bumped up to the list because they are more recent and they might be going back to work sooner? So that would be a consideration. Do consider patient age whenever you can. Our infection control person here, and this isn't policy, this is just something they mentioned to us, is consider grouping the younger patients together if possible because they tend to be more asymptomatic. So maybe if you have a class of 4 people or 5 people that are 50-year-old and scheduling allows you to do it that way, which it might not, then you would think about that. This isn't an absolute, this is just another sidebar. And obviously you have to look at comorbid burden. Patients with diabetes, they already have heart disease, but patients with diabetes, heart failure, AFib, maybe that's a patient you'd want to bring in a little bit later, class 3, heart failure, than somebody you might want to restart a little bit sooner. So the comorbid load would be something you have to consider. Next slide. Then there's a special considerations you have for patients that have tested previously been tested COVID positive, and that's been documented. Now, some of these patients will be non-hospitalized, and a general rule of thumb, it may vary based upon your infection control policies or infectious disease policies, but you might say, well, we're going to wait, assuming the patient feels fine, at least 14 or at least 21 days for considering starting a patient after waiting at least 14 to 21 days that they're asymptomatic. So they have to be asymptomatic for that period of time before considering restarting them or starting them in cardiac rehab. If the patient's been hospitalized, that was the non-hospitalized patient that's positive. If the patient's positive and hospitalized, it might take a greater level of thinking. if they had complications in terms of an ICU stay, and especially if there were some cardiovascular complications, troponin bumps and whatnot. Then maybe you have to, and if there's a reduced EF, then before starting that patient, you might want to consider talking with the patient's physician, cardiologist, primary referring doc, just to make sure. They'd have to be 14 to 21 days post to symptoms, but still before starting them, maybe do a quick check to make sure the patient's cleared to start. And it would be especially important in an automatic referral model where sometimes you're just getting the referral automatically versus some kind of trigger from the physician. And another model you might want to consider is a risk stratification, model. And the risk stratification would consider not only some of the things we talked about above, hospital discharge date and age, comorbid load, but think about their functional status. If you've got somebody that really is, in fact, let's go to the next slide because this might do a better job of explaining it. One way you could break this out, if you've got somebody that's going to get a big benefit but low risk, they have a poor functional performance. You talk to them on the phone and they're doing maybe 1 or 2 flights of stairs, probably 3 or 4 METs in their activities of daily living, but they don't have much of a comorbid burden. They don't think that they're going to be another rehospitalization risk for heart failure or AFib or something like that. That might be one of the patients you consider starting first because they can benefit a lot by functional improvement and they represent low risk for having a problem. We don't want to hospitalize patients, not because we don't only want to hospitalize patients, but also because we don't want to burden the hospital when already many are taking care of a lot of increased number of patients as well. Then you might have your moderate risk people that you consider layering in next, and those would be the people that are functionally fine, very stable, but they're doing well at home. Their ADLs might be at the 3 or 4 level, and they might have a peak ADL of 5 or 6. So again, functionally they're doing well, but they're low from a comorbid status. Maybe you don't think of starting them right away. You hold off on them a little bit if you've got limited space because of spacing in the room. And then there's a third group that you might say, let's get rehab up for 2 or 3 weeks and get our sea legs underneath us, get our kinks worked out. And these would be people that are probably functionally low, again, 3 or 4 METs peak, but they might represent increased burden to the health system. They've had a lot of hospitalizations, they've got a lot of comorbidities, their therapies are complicated, et cetera. So you could stratify it. So what I try to provide on the above slides is some things to think about in terms of how you restart your patients. Many of you might say, well, we're just going to restart them all as best as we can. Then I respect that. I just wanted to give you some additional information to think about. Next slide, if I could. So what I'd like to do is we're still talking about patients and staff, and I'm going to come back to some process stuff later on. But I'd like to shift gears and introduce Diane Perry again. She's from the University of Michigan, and she wants to talk a little bit about our stakeholders. And these stakeholders are not only our coworkers, which are stakeholders, but also the patients. So Diane, if you're on the line and ready, I'm going to let you cover the next 4 or 5 slides from this patient stakeholder perspective.
Thank you, Dr. Kitane. I'm so grateful to be partnering with you today on this webinar. As you have started to outline, this pandemic has forced us all to close our doors and rethink the way cardiac rehabilitation needs to look as we anticipate the reentry process. My focus today will be on the primary stakeholders, as you said, those being our patients and families. However, we need to also acknowledge our other essential stakeholders, our staff. How do we meet the needs of our patients and staff with sensitivity and in this time of uncertainty? Next slide. For many patients receiving a new heart diagnosis, it's like a seismic shift. They've gone from apparently healthy to a state of uncertainty. And this results in an array of emotions that stir up sensitive questions, such as, am I going to die? Why did this happen to me? How will I or my family manage? The arrival of COVID-19 creates additional concerns, especially since these patients are now considered most of them vulnerable in contracting this virus. Next slide. If we look at the stages of recovery for any chronic disease, we know that it is more cyclic than linear. However, there tends to be a specific progression in the way we ultimately cope. COVID-19 adds another layer of emotions around the recovery process. In stage 1, our patients survive the initial crisis. They receive a diagnosis, medical intervention, and treatment, and are sent home to recuperate. With COVID-19, they now have concerns around their fragile state of recovery and the risk of contracting the virus. In stage 2, they begin the coping process, relying on strategies they can draw upon from past experiences and support from family and friends. However, now they worry about physically attending programs like cardiac rehab. Will appropriate safety measures be in place? And they also have the added concern around job and financial security as a result of COVID. They wonder if the risk is worth the benefit. In stage 3, we know that 80% of all patients who receive a cardiac diagnosis will experience some type of depressive symptoms. These usually subside over time as they're able to reconnect with others who have shared experiences and rely on the support of family and friends. But how does this stage look during COVID when patients are in quarantine and having to social distance? Many may be living alone, and some lack the resources to connect through social media or to secure basic needs. Finally, in stage 4, our patients are learning how to live with a heart condition while navigating risk. The big question here is, what will the new normal look like? And will they have all the resources they need to thrive? Next slide, please. Those of us working in cardiac rehab know there is no greater time than now for our services. Historically, cardiac rehab has been the glue connecting patients to the resources and support they need to thrive. In order to successfully reconnect our patients to our programs, it's imperative that we amplify the patient voice. Now is the time to bring them into the conversation. We can do this by soliciting patient advisors and sharing patient testimonials or blogs, using social media platforms, patient portals, and messaging systems to push out surveys. These are all ways to better understand their perspective. Here at Michigan Medicine, like many of you, we've continued to reach out to the patients that were with us prior to COVID, as well as the new patients in our referral queue through telehealth calls. Although many may not be receiving reimbursement now for these calls, we understand the importance now of establishing rapport to ensure greater enrollment when our doors do open. Another option is to consider holding a town hall meeting specific to your patient population. This will provide a platform to discuss logistical concerns and options in real time. This town hall should consist but not be limited to a panel of experts within your cardiac rehabilitation department, such as your medical director, rehab staff, EPs, nurses, social worker, and someone from infection control or billing and insurance. But the most important expert presence will be the patients themselves. They know best what they need to have in place to feel safe and supported. We need to acknowledge that some may never opt to come into our centers, so this may be the place to discuss new options available, such as home-based cardiac rehab. Next slide. In order to continue our mission of bringing joy to our patients and opportunities to thrive, we are called to think differently. The model of cardiac rehab has evolved many times over the years, and this time is no different. We need to be willing to transform the way we deliver cardiac rehab. Patients will continue to seek cardiac rehab programs that provide support, camaraderie, while providing safe, structured guidance with exercise and behavior change, whether it's in a modified center-based program, a home-based program, or a combination of both. In a time when we are being separated from one another, we understand that as human beings, our physical and emotional health and well-being is dependent on those connections we make with one another. Cardiac rehab has and will continue to create these vital connections that allow our patients to thrive and improve health outcomes. Next slide. Finally, it is important that we all work within each of our individual institutions' guidelines to ensure safety and consistency as we begin to re-engage with our patients. Providing continuous support and social services is vital, not only to our patients, but to our staff as well. Many of them are feeling an array of emotions around their own health and safety during this time. Many also have concerns around job security. Allowing space for them to express their feelings and providing coping resources can help to redirect their worries and shift focus and energy towards creating new possibilities. This is truly a unique time in our history. Change is on the horizon. So now's the time to partner with our patients to redesign the look of cardiac rehab and create something spectacular. And now I'd like to give it back to Dr. Catane.
Thanks, Diane. That was perfect, wonderful. Before digging in on the last section of the webinar and opening it up for commentary and questions, I just want to pick up on something Diane said and reemphasize, and that we've all been operating our brick and mortar programs in one way for decades, and yet we know we've struggled with enrollment and referrals. Referrals are getting better, but enrollment still struggles. And Diane's correct, and many others are correct, that this could be an opportunity, or this is an opportunity for us to change how we do things. And a model 6 months from now or 6 years from now could still keep remnants or important parts of what we learned here during this COVID crisis that can allow us to modify how we do things, make our things more efficient, how we schedule, how we connect with patients at home who can't make it to rehab. So as you look to restart, don't run away from, don't close down maybe too quickly what you're doing now, staying connected to patients, because I still think it's valuable. So I want to shift now to some of the non-patient aspects, more kind of operational things that have to do with cardiac rehabilitation as we open up. And my first point, and I mentioned it earlier, is meet with your infection control representative for your institutions. We did this about 3 weeks ago, and 3 of them came in, and they were wonderful. All the questions that we had about distancing and PPE and all those kind of things, they really helped address for us, and we all left that meeting much better. They walked our space, and it was very, very helpful. And again, what I'm about to cover here, it might just be coming out of our thinking, our location. Remember what I started off with, all decisions are local, so you have to meet with your local people to get some direction. In terms of staff PPE, at least what we're trying to propose is that mask and gloves for all staff, and patients come in the door with mask, be checked in with mask, and if they can exercise with a mask, fine. Some won't, and if that's the case, then they would take off their mask. So we're keeping it at that level for both staff and patients. Encourage you, clean your blood pressure cuffs in between each patient, and you follow the manufacturer recommendations for dry times on the wipes that you're using to clean the cuffs, but also align the frequency of which you're taking blood pressures to clinical need. And this is an example of making program change. You don't need to take blood pressures on all patients every exercise set or every exercise class. If the patient's demonstrating that their blood pressure is normal after 3 or 4 visits, then stop taking blood pressures unless there's a clinical issue that demands it. And the same thing for resting blood pressure. If the patient comes in with good resting blood pressures every single morning and they have no signs and symptoms, and no clinical indications, and after 3 or 4 visits, maybe you don't have to take blood pressures on that person every single morning or after exercise every single morning, every single session. So you can make some clinical decisions, and that means less blood pressures, less immediate patient contact, etc. And then the same thing for ECG tele. If you know me, I've really encouraged sites to not monitor all ECG tele, monitor all patients, all sessions. This would give us an opportunity to maybe some kind of risk stratify your patients. Those patients that are on dialysis or LVAD or on milrinone, maybe you're monitoring them for all 36 visits. But if you've got some uncomplicated patients, clinically quite stable, they've showed you 3 to 6 visits of really good ECG tracings, then maybe you start to drop that patient off of every session ECG tele. You can make the decision, you can put them back on, whatever you think is clinically indicated, but we're getting a reboot here, so this is a good time to make that change. And there might be some sanitation issues with the pouches that we use for our telemetry units. Maybe you have pouches now with their names on them, and everybody gets their own pouch, and those are held in paper bags that are allowed to dry, and they get it out, and the bags are stored away and brought back out for the next session with their name on it, and they go ahead and do it that way versus trying to share pouches or the hassle of rewashing them. Do try to wipe down exercise equipment between patients in a class. So if Mary's getting off treadmill 1 and Mike wants to get on treadmill 1, that exercise equipment, all the touch points are wiped down. And again, follow manufacturer specifications for dry time. And then for sure, wipe down equipment, and touched surfaces. So these might be your horizontal surfaces or touch surfaces in between classes. Well, if you ran an 8 o'clock class and a 9 o'clock class, you may have to say, well, maybe we have to run an 8 o'clock class and a 9:20 class now, because you have to allow dry time and allow time to wipe down everything in between classes. Just a consideration. Next slide. So should we do some patient screening? And I think all your systems probably already have these in play. For the patient's first visit, call them beforehand to let them know what symptoms you want them to look out for. Check their symptoms. Don't have them come in if they have COVID-related symptoms. And if they're feeling well, if they're not feeling well otherwise, don't have them come in. So there's a little bit of just clinical triaging there as well, right? But you don't have to call them before every subsequent visit, but they should be aware of, when they come in that day, what are the day of concerns that they have that they should recognize, and maybe I don't need to come in today because I'm feeling a little bit symptomatic. You'll probably have some in-person facility door screening, and you'll probably have some, well, you will have some in-person at program check-in screening where you'll check with them again. So these would be symptomatic patients you're screening for. We do know there's probably a 3 to 9 day window when patients could be positive and could be asymptomatic and infect others. But we're trying to screen that out as best as we can with these screening processes. We encourage, and I'm sure you do at your facilities, that non-essential visitors not be allowed to come into the building. So maybe the spouse of somebody who come and sits in a chair in the waiting room while the patient is being cared for, well, they'd have to wait out in the car or outside. Now, this is different than an essential support person, and this might be an interpreter that has to come into your class. So you'll have to make that on a patient by patient basis. Next slide. So you have to think about some other class scheduling or physical distancing concerns. The number of classes that you have may have to increase because you're going to have probably fewer people in a class because you have to distance. And instead of maybe a morning program, maybe you're running from 8 until 3:30 now because you're having more classes with 4 or 5 people in the class rather than, or 6 people in the class, rather than 5 classes of 8 people in the class. But you've got to spread this out because you don't have enough room in your physical space to spread 8 people out, but you've got enough to spread 4 people out. So you may have to increase your number of classes, and how much space you have will dictate the number of patients in a class. If you're in a medical fitness center, then you might be able to say, well, we can really spread out and see 18 patients at once, as long as we're keeping this 6 to 8 foot barrier in between patients. And again, relative to classes, you have to increase as you increase your class schedule, you may have to make sure you increase your time in between classes because you have to wipe down equipment and surfaces in between the classes. And then you can consider relative to exercise modalities. You can rotate these, or shut them down if you want, but you can rotate these so that you sanitize one treadmill, but it won't be used again because it has to dry until after the next class. The next class reconvenes. So you might have a class in between where a treadmill is not used at all. You try to avoid face-to-face equipment. So if you have 2 treadmills or 2 bikes facing each other, try to relocate the room so that's not the case. And you want to have at least think about having a piece of equipment in between any 2 patients so you have some distancing that way. And these are just a couple examples. Everybody on this webinar is smart enough to think of ways that you can social distance or physical distance these. I'm just trying to get you thinking about things you might want to consider in your mode, in your center. And a lot of it will be driven by the number of pieces of equipment, the physical footprint for and layout for the room. Those will be big drivers of how many you can put in a class, and that will probably drive how many classes you have to have. Next slide. So as as Diane said, and I've mentioned 2 or 3 times, now is the time to seize this reboot and start to maybe applying lessons that we've taken away from COVID-19 to future cardiac rehabilitation. I directly asked you to consider the amount of ECG tele you do and the amount of blood pressure monitoring you do, align that with clinical need. We spend so much time with activities that don't necessarily, not so much, we spend a fair amount of time with activities that don't necessarily give us a clinical return, and I'm asking you to use best thinking, clinical judgment to try and align these processes together. And then, as I mentioned also earlier, after restarting your facility-based program, maintain some of these other ways you've used to keep in touch with patients that you might not have been in touch with before because they couldn't come to your program because of return to work, or they had transportation issues or dependent care issues. And I think of whether it's asynchronized or synchronized telephone calls. I think of synchronized telephone visits where we're actually, telehealth, where we're actually talking to the patient while they're exercising, viewing the patient while they're exercising. These are all things that we can keep in place and build our schedules so that we can accommodate these other patients as well. And this helps grow the total number of patients we're touching now, which has to do with our enrollment numbers and the percent of people that we're helping through cardiac rehab. Next slide. Right, so what we're talking about, I have 2 different models here for you. The slide on the left was kind of old cardiac rehab, pre-COVID. And you can see that in blue there in the center, we were touching about 25% of eligible patients. The red represents how many patients we were caring for through home cardiac rehab, and not too many. And there's this whole gray area of the number of patients that we weren't touching. Post-COVID, or independent of COVID, where we would like to go in the future, but in conjunction with thinking about how COVID has helped us, we want to grow that area in the middle. We want to get more patients into facility-based cardiac rehab. We want to do that, but we also want to really grow the red. We want to grow the number of people we're touching with home-based cardiac rehab or hybrid cardiac rehab. And in doing so, growing both of those, we shrink the gray area, the number of people that are not touched. Next slide. So what we've done at Henry Ford is we do use a hybrid combination of facility and telehealth model where we're actually seeing the patient when we're while they're exercising. I can tell you that Blue Cross is really looking at trying to help programs start up with this. It's still they do cover it, but getting it in play requires some operational and logistical stuff. So they're willing to help support this. Hopefully they'll take that on, but this would be the future to where we want to go to, kind of a hybrid or home-based model. Finally, I just want to conclude on there are other issues we have to think about, especially as we alter our program. Can you still use the same patient education model you used before? Or do we have to think of a different way to deliver our education? How did you deliver education when COVID had us shut down? Can we pull any of that forward? And for some patients where there might have been a time window of how long they could stay in the program, number of weeks rather than number of sessions, their insurance company might have said you have to be done by April 1st or May 1st. Because of COVID, will that date change? So there may have to be some background work to help those patients get extensions or appeals to when their initial approvals were given or verifications were given. And then also you've got this phase 2 program now, maybe with more programs, more sessions in operation. Where do we stick in phase 3, and how do I integrate pulmonary rehabilitation? What's the balance? What's the confluence? What's the conflicts between staff scheduling, space? All these things are another layers. We've just covered cardiac rehab, traditional phase 2 early outpatient rehab today. And And those other issues have to be considered as well as you restart. And again, good thinking, how you spread it out, how you implement this. It just takes good logic and good. We're smart enough to do this. Just good planning to make it happen. There maybe have to be some changes, but it's good planning. So let me stop and finish where I started. And again, thank the Michigan Department of Health and Human Services for the grant funding, but also for sponsoring this webinar, MSCVPR for short notice putting it together, and then Diane Perry for U of M for her contributions to the presentation material. So Karen, I'm a couple minutes, 5 minutes or so longer than I wanted to run, but I don't know how we want to do this, but we can certainly entertain any groups, questions that come through the chat box. And again, our answers might not be magic answers, but if we can help, we're certainly willing to help do so.
Yeah, thank you, Dr. Catane. And I do want to remind everyone that is on the call and on the app that this webinar is being recorded and will be made available through MSCVPR. Thank you, Dr. Catane and Diane, for your presentation. We can now move forward with the discussion. As I mentioned, we can take questions from the chat box, and then we'll move into questions from people on the line. Currently, there are no questions in the chat box. To unmute yourself if you're on the line, you press *6. Okay, so it looks like we do have a question from the chat box. Does Medicare cover any telehealth?
So I can help with that. And at this time, and I've spoken even this morning with people representing AACVPR. At this time, Medicare does not cover telehealth for cardiac rehabilitation. We've seen various bulletins. We've seen some material from AACVPR. I can tell you that ACC, AHA, and AACVPR are leaning hard on CMS to consider reimbursing during this crisis period, reimbursing for telehealth. And I would hope going forward. But the short answer to that question is no, not at this time. But people are working on it.
Thank you. The next question is, Dr. Catane, do you have an anticipated date to open your cardiac rehab?
So we've decided, and all planning is heading towards May 18th is where we're at now. We plan to ramp it up in 2 phases, take the first 2 weeks, and now I'm trying to be very practical to get some of the patients that we think that might be functionally a little bit lower but stable, and some of those people that are functionally a little bit better but also stable. We want to start those patients first. And we're not going to start all patients the first day, right? If you have 25 patients starting that first day back, think about that. 25 ITPs you just passed out, right? 25 ITPs you got to complete that first day as they come back. So we might start with just 2 or 3 in a class and I think we have 5 or 6 classes or 4 or 5 classes planned just to get things going. And then we'll ramp it up to 4, 5, or 6 people in the class at some of our different locations. So we're targeting May 18th, giving ourselves 2 weeks to ramp up, and then hopefully by June 1st, it's all classes that we can schedule at all sites and all patients.
Great, thank you. I don't see any other in the chat box.
So I'm seeing one. It looks like it came in from Laura.
Okay.
And it asks, is there merit in bringing in the higher risk patients first while there's fewer patients in the gym? And I think that's an outstanding point. So maybe you have your earlier classes for your older people or people that might be concerned with having a higher they're stable, but they might be having a higher comorbidity load. So maybe you bring those patients earlier in the day and clear them through first. Again, we're all thinking out loud here, so I can see some logic in that. Another question came in, Karen. I'm just reading it if it's okay.
Yeah, that's perfectly fine. Thank you.
About wearing a mask. And we've played with this on ourselves and with others, to have them walk with and without a mask. And in general, having patients come in, obviously they have to come in with face coverings. If they don't have one, we supply it. And in general, most people are able to go for a walk and exercise with a mask. Some people, as they're starting to exchange a higher volume of air, then you may say, you know what, you can pull the mask down and then, or take it off, but then re-put it on when you're done with the exercise. That's a plan that we're looking towards right now, and that is consistent with a couple others I've talked about as well. So maybe start with it and see how the patient tolerates it. Many do. A lot of our transplant patients wear their mask already now. Wear their mask already just for pre-COVID rehab. Others, Karen?
I am not seeing any others in the chat box.
I can read one more. This is Adrian, Dr. Gatan. So Pam asks, are they able to exercise while wearing a mask? Or sorry, we had that one. Megan asks, do you anticipate dates to start up phase 3 again?
We're still working on that, and I will say it's not because of some of the concerns that we've talked about so far. I just want to get shaken out. What's the spacing in the scheduling that goes with phase 2 before we start to layer in phase 3 schedules. So within a week or two, we'll, again, Bobby, by the end of May, we'll know how this is playing out, and we'll find holes in our schedule. It might be on opposite days, Monday and Friday or something like that. Instead of a 3-day per week program, maybe go down to a 2-day per week program. But I could see by June 1st.
We experienced some technical issues at the end of the Q&A and would like to apologize. This webinar will be recorded and made available through MSCVPR. We would like to thank you all for attending. Have a wonderful afternoon, everyone. Stay safe and well.